Anesthetics were developed out of the need for more humane surgery. This picture depicts one of the first public displays of anesthesia by William Morton in 1846. The inhaled agent in this case was ether. We've since moved on to using different agents for anesthesia, thankfully. The ideal agent causes loss of sensation and consciousness, amnesia, and relaxation of skeletal muscles. Anesthetics can be either inhaled or intravenous. Either way, they must cross the blood-brain barrier, either through diffusion as a lipid-soluble molecule or through active transport. The potency of an inhaled anesthetic is expressed in minimum alveolar concentration, or MAC. MAC is defined as the concentration of a drug that induces anesthesia in 50% of patients. It's analogous to the ED50 concept, or median effective dose, which you learned about in pharmacology. Another important concept is the solubility of drugs in the blood. The more soluble the drug is, the more that must be given in order to produce a change in the partial pressure of gas in the blood. What drives gas from blood into the brain? That is, the partial pressure. So, the less soluble that a drug is, the quicker the partial pressure rises, and you have a faster induction of anesthesia. The potency of anesthetic also correlates with its lipid solubility. The more soluble, the more it is able to cross the lipid membrane. Thus, the higher the lipid solubility, the more potent the drug, and since less is needed, this is inversely related to the MAC. The rate of induction is also influenced by the alveolar ventilation. Let's think about things that affect the respiratory rate. People who were pre-medicated with benzodiazepines or opioids would both have decreased ventilation rates. Thus, they would also have lower alveolar ventilation. And this means that it takes longer to induce anesthesia. Patients who have emphysema or atelectasis have more dead space, so in those patients it will also take longer to induce anesthesia. Inhalational anesthetics pass through the lungs into the blood, and the blood next travels to the brain. So when cardiac output increases, more blood passes through the lung parenchyma while receiving the same amount of anesthetic, so the gas becomes more dilute in the blood, and thus the partial pressure in the blood is reduced. This would also increase the time to induce anesthesia. Now we'll discuss the inhaled anesthetics. Although these drugs have been used for years, the mechanism remains unknown. There is evidence that the oscillations that connect different parts of the brain are interrupted by anesthesia, and that lack of communication is what leads to the coma-like state of anesthesia. Most of these anesthetics are sufficiently potent to induce surgical anesthesia. Nitrous oxide is the exception. It is not potent enough to produce surgical anesthesia by itself, but it potentiates other anesthetics, so it's commonly used in combination with other drugs. The choice of inhaled anesthetic depends on the additional effects, such as how much hypotension they cause or the degree of skeletal muscle relaxation. It may also depend on the safety of the gas. Some gases are too flammable to be used safely. All inhalational anesthetics decrease the respiratory rate. They also depress the force of myocardial contraction. They also frequently cause both nausea as well as vomiting. So antiemetics are commonly prescribed in the post-operative period. Most of the anesthetic is eliminated simply by breathing, but small amounts are metabolized by the liver and kidney. Halothane hepatitis occurs in about 1 in 15,000 patients. Methoxyflurane is metabolized into free fluoride ions in the liver, which can then go on to be actually nephrotoxic. Rarely, nitrous oxide can diffuse into air-filled cavities in the body, causing pneumothorax, obstructive intestine, air emboli in the bloodstream, and some similar problems. We'll discuss malignant hyperthermia in a few moments when we discuss dantrolene. IV anesthesia is more rapid,
smoother, and more pleasant for the patient, since inhaled anesthetics are often malodorous. However, you should be aware that you cannot monitor the depth of anesthesia as easily as you can with inhaled agents, which is one of the reasons why we also use inhaled agents. Now, do you recall on which receptor the barbiturates and benzodiazepines act? Hopefully you remembered that these act at GABA receptor. Now when GABA binds to the receptor, this opens up a chloride ion channel. Now we've already discussed the side effects of these drugs, which you definitely want to know, but remember that one of the big ones is respiratory depression.
Ketamine is a drug that blocks neuronal excitation by acting as an antagonist at the NMDA glutamate receptor. Interestingly, ketamine is the same class of drugs as PCP, and so it's not surprising that it may produce hypnotic or dissociative effects on the CNS, similar to PCP. It can also cause amnesia. Afterwards, it can often lead to bad dreams in adults. Kind of sounds like a bad trip. Opioids like fentanyl and its derivatives are commonly used. And what is their mechanism of action? They act on the mu receptor. So I like to draw it like this because it makes me remember that it's a receptor. So the O is for the opioid, and this is your receptor, but it's also the M for mu. So that's a nice way of remembering that opioids act on the mu receptor. Now we have propofol. Propofol is really the most commonly used anesthetic. What's the mechanism of action? It potentiates GABA, and it also inhibits NMDA glutamate receptor activation. It's popular because it is short-acting, meaning that it only takes about 30 to 50 seconds from injection to put the patient under. That's pretty rapid. Compare that to midazolam, which takes about 2 to 3 minutes to induce anesthesia. Also, once you've stopped propofol, the patient will wake up within 5 to 10 minutes. Local anesthetics are commonly given with epinephrine to enhance their local effects. How exactly would epinephrine do this? Well, let's think about it. So epinephrine causes vasoconstriction. By causing vasoconstriction, we're also decreasing the blood flow to the area. And by doing that, you're also decreasing the washout of the anesthetic, which effectively means you have more anesthetic there. So if patients are allergic, most commonly to esters like procaine, then you should give amide drugs or pre-medicate with antihistamines like diphenhydramine. That's also known as Benadryl. This is one that you might run into, and why it is worth paying attention to that mnemonic that says that amides have 2 I's in their name. Now if you have a question where the patient is allergic to one class of drug, the answer choice will be the other class. And you will know this because it will likely be the only one of the answer choices that belong to that class. As far as side effects go, these drugs are usually pretty safe when given correctly. However, you should know that they can lower the seizure threshold. In a situation where you're worried about this, you should be careful and perhaps give a benzodiazepine in patients with that propensity. Now you should also know that they can cause arrhythmias, particularly upon accidental injection into the bloodstream rather than the local area. Bupivacaine is really one of the ones you want to think about in terms of cardiac effects. Lidocaine can be used therapeutically in certain arrhythmias. As I mentioned, these are sodium channel blockers, and you can learn more about that function in the cardiology lectures. Now let's discuss the neuromuscular blocking drugs. These drugs are used to relax skeletal muscle, most commonly during surgery. They are classified as either depolarizing or non-depolarizing. Now these are very descriptive terms that literally are telling you what the drug does. To understand the difference, let's just talk quickly about the way that neurotransmitters are released. So an action potential is going to travel down the axon into the presynaptic terminal. When the action potential gets to the presynaptic terminal, it's going to cause these calcium channels to open, which leads to a calcium influx into the presynaptic terminal. What that does is sort of activate these vesicles to fuse at the membrane and release neurotransmitter. And in this case, we're talking about acetylcholine. So acetylcholine is released into the synaptic cleft, and then it binds on these nicotinic receptors at the motor end plate, and that causes depolarization. This binding can be blocked competitively by non-depolarizing neuromuscular blockers. These are agents like curare that bind at the nicotinic receptor, but they don't cause depolarization. The effect of curare derivatives can be overcome by acetylcholinesterase inhibitors. Basically, what you're doing is just increasing the amount of acetylcholine at the synaptic cleft so it's more able to compete with curare. The binding of acetylcholine can also be blocked by depolarizing agents like succinylcholine. The difference between these and the non-depolarizing agents is that once they bind, they actually cause depolarization, which leads to a muscle contraction. Normally, acetylcholine binds to the membrane and then it dissociates. However, succinylcholine is not metabolized by acetylcholinesterase, and so it stays at the receptor for a long time. Phase 1 block is the time when the membrane is depolarized for such a long time that it is unresponsive to further stimuli. Now, initially, there's some muscle fasciculation, but eventually it results in flaccid paralysis due to resequestration of calcium by the sarcoplasmic reticulum. Phase 2 occurs with continued exposure to succinylcholine. The membrane repolarizes but is desensitized, and so it is not responsive. Phase 1 and 2 differ in their response to acetylcholinesterase inhibitors. Phase 1 flaccid paralysis is intensified by acetylcholinesterase inhibitors. In contrast, Phase 2, which is when the succinylcholine begins to disappear from the synaptic cleft, may occasionally be reversed by acetylcholinesterase inhibitors. One thing to keep in mind is that the response to these drugs is unpredictable, so you should undertake their use with great caution. Okay, now it is time for another flash quiz. So a patient comes in for an outpatient procedure. She has an allergy to esters. You have a choice to give her either procaine or lidocaine. Which should you give? This one you should have definitely gotten. You should give lidocaine. Because of the allergy, you should not give this patient an ester. Remember that one way to tell whether a drug is an ester or an amide is that amides have two I's in their name, like lidocaine. To better understand why and how dantrolene works, let's first discuss one of the conditions it treats, which is malignant hyperthermia. Malignant hyperthermia occurs in patients with a genetic susceptibility, so make sure you ask about family history before any surgery. Classically, it is triggered by succinylcholine, right? This is one of the neuromuscular blocking agents we just talked about. Any depolarizing neuromuscular blocking agent can elicit malignant hyperthermia, not just succinylcholine. The heat is produced by sustained contraction of the muscles due to a genetic mutation causing failure of the sarcoplasmic reticulum to resequester calcium. The sustained calcium in the muscle causes continued association of the actin and myosin filaments. Dantrolene is the treatment for malignant hyperthermia, and what it does is prevent further release of calcium. It does this by inhibiting the ryanodine receptor. This blocks calcium release from the sarcoplasmic reticulum and stops the sustained contraction.